Here are my disclosures. I think you've seen a lot of this. There's obviously multiple mechanisms for TR, and functional TR is more than 80% of the mechanism. So I'm going to present a few cases and talk about kind of our decision making. So the first was a 71-year-old female who was a pretty healthy lady, used to walk miles at a time, and really about 6 weeks prior to being referred to us became symptomatic after a viral episode. And she was quite symptomatic. She could hardly even walk. She went from class 1 to class 3 in a very short time. Otherwise, her kidneys and liver were quite normal. And this is what her echo looked like. And if you look carefully, there's a segment of leaflet that's prolapsed on the anterior leaflet and a fair amount of TR. And her RV's already started to dilate. So the background, as you've already heard, the tricuspid valve from a surgical standpoint is really the easiest valve to access. It's the most anterior structure. You can get it from a sternotomy or thoracotomy very easily, but the mortality is high. And the reason for that is once you have TR, it's a marker for RV dysfunction, and patients typically die from multi-system organ failure, primarily liver failure. And so because of that, we started to look carefully at what are the causes for death and what are the ways to predict it. And so many years ago, we looked at how does MELD impact mortality from tricuspid valve surgery. And we saw a nice stepwise progression based on preoperative MELD score and operative mortality for patients with tricuspid valve surgery. So I think Mike Mack mentioned MELD less than 14. When you get over a MELD of 15 or greater, the mortality jumps up substantially for tricuspid valve surgery. So in this sense, we do think referring patients early is better, and we don't want to wait for the kidneys or liver to fail. The problem is many of these patients are not symptomatic when their TR is, even if it's severe, but before they have liver dysfunction, and that's really, again, a marker of RV dysfunction. So we then wanted to try to develop a risk model. As you know, the STS has developed nice risk models for aortic valve surgery, mitral valve surgery, repair, replacement, for CABG, but there is no risk calculator for isolated tricuspid valve surgery. So in a collaboration between the state databases in both Virginia and Michigan, in a collaboration between Steve Bowling's group and our group, we tried to develop a risk model. And we used a patient base of 2,000 patients undergoing isolated tricuspid valve operations over a very long time period, over 12 years. The majority were repaired, so about 15% had replacement. And the operative mortality was 9%, so quite in line with the national STS benchmarks. The other important thing to note is major morbidity occurred in 40%. So even though these patients, we can get them through surgery, a lot of them do have significant complications. So this is what we ended up undergoing or developing a mortality calculator, which looks a little bit cumbersome. In reality, it's fairly simple, and it's something that we have in our clinic when we're evaluating patients. So we take a patient's age, and depending on the age, it may impact their risk score. If they're female, it's a higher risk if they had stroke previously, if they have on hemodialysis. If they have chronic lung disease, as you heard the previous speaker talk about pulmonary hypertension and that effect on tricuspid valve risk. NYHA class, again, many patients out there have less significant TR or less significant symptoms, but have significant TR, and they're not referred. So oftentimes when they're referred, it's almost too late. And then if they've had a reoperation or if they're an urgent case. And in terms of how this model performs, actually it's quite good with an AUC of 0.74. This is actually slightly better than the STS national database for all the other types of surgery. So we'd love to validate this in other databases and other populations. So the patient I just presented met some of these criteria. She was female over the age of 70, and her clinical risk score was 6, which put her at a mortality risk of 9%. And a morbidity risk of a little less than 40%. Now, this patient didn't really have a lot of good options outside of surgery at that time. This was a couple of years ago, and we thought that a transcatheter approach was still quite novel. And so we offered her surgery, and we tend to perform a minimally invasive approach for a couple of reasons. One is we think the bleeding is less, and so bleeding is really a death sentence for anybody undergoing tricuspid valve surgery, because what happens is they lose their blood volume, they get it back, and that stresses the right ventricle quite a bit. The second thing, at least in my viewpoint, is because you don't disrupt the pericardium anteriorly, it gives the RV less room to dilate. Post-surgery, what we really worry about is RV dysfunction and RV dilatation after tricuspid valve surgery, even any surgery. And when you think about what's the difference in patients who have a right-sided acute myocardial infarction where there's a closed pericardium, the treatment in the CCUs give a ton of volume. If you do that in a surgical patient after cardiotomy, that's a death sentence. So you can close a pericardium, and I think that could be a benefit as well. I won't go into all the technical details, but in this particular patient that I showed the echo before, you could see the prolapse of the anterior leaflet, so we resuspended a cord and closed the anterior to posterior commissure, sort of an Alfieri type technique, and put a ring on, and you could see she was left with no residual TR. So what about patients with left-sided disease? You heard a bit about that earlier, and there's been some conflicting data as to patients who have left-sided disease. Does that really impact outcome if they undergo a tricuspid operation? So this was a study we did years ago, again, in the state of Virginia, and essentially found that if any patient undergoes an additional tricuspid valve operation, the mortality and complication rates essentially double. Now, it's not the tricuspid valve repair that does that, it's the fact that they needed a tricuspid valve operation. So this was a little bit more historical because more recently, Vinay Badwar looked at the national STS database 2 years ago and stratified patients by severity of TR and essentially found that there was no impact on mortality if the patient underwent a tricuspid valve repair or replacement. However, there is still a significant impact on morbidity if a patient required a tricuspid valve operation. So I think the data is still mixed, but in essence, there is a population, I think, that still might benefit. And so here's a patient that we evaluated earlier this year, a 71-year-old female. She had a history of an ASD repair at a young age, had chronic AFib for probably about 20 years. And was moderately symptomatic. Again, very recently she'd been active and over the last few months developed class 2 to 3 heart failure. And this is what her echo looked like. And so she had kind of the epitome of the type of left-sided disease that a surgeon would see, a central MR jet that's severe with a lot of leaflets, so that's going to be an easy valve to fix, and a large ASD, which I'm sorry it's not playing here, but it was about a 3-centimeter ASD, and of course you could see the RV is massively dilated with severe TR. The TR was certainly out of proportion compared to the MR. And the other thing to note is that the flow was still left to right across the ASD, which is important. And you can see her CT, as you'd expect, her RV is massively dilated right up against the sternum. And so we utilized a minimally invasive approach and repaired both valves and fixed the ASD. And patients like this can do quite well. You can downsize both valves, get a very good repair. This is really a disease of the atrium in this case, where both atria were extremely dilated. The function overall was good of both the right and left ventricle, except the RV was significantly dilated, and fixing the ASD helped substantially. And so this particular patient did exceptionally well, and at follow-up has still remained class 1. So I think to conclude, in terms of which patient could get surgery, I do think there are selected tricuspid patients that can have excellent outcomes. As you heard already, avoiding patients with advanced liver disease, MELDs over 15, poor RV function, and irreversible pulmonary hypertension. It's kind of the same theme I think the last few speakers have indicated. The risk calculator that we've developed could be a useful guide. Addressing left-sided disease is certainly beneficial. And the need for transcatheter approaches really is great because there is a definite insult that the patients have trouble getting over with even a minimally invasive beating heart on pump tricuspid surgical repair or replacement. So thank you. So Steve's going to finish up, and hopefully we'll have time for some discussion. Steve's a cardiac surgeon, by the way.
Yeah, I'm a cardiac surgeon, and I'm supposed to say things that only surgeons know. So I'm not sure that we know anything different, but we do know that TR is bad. I'm a simple surgeon. I'm from a small Midwestern town, and I tend to think of things in a simple way. TR is bad. Write that down. So is it really bad? Well, first of all, the patients feel terrible. They're really fatigued. They're terrible. They can't do anything. And they die. Both severe and moderate TR have a mortality ding. So that concept that, we'll give them some Lasix and they'll be fine is just wrong. TR is bad. There's two big studies, the NATH study, which you've seen, the Pilsky study. TR is bad. TR hurts your quality and your quantity of life. If you have a choice of having TR, say no to TR. Now here's me. TR is really bad. I have MR and TR. I have 2 flat tires on my car. I go see the mechanic at the gas station, only it's not a mechanic, it's Molly. So now Molly can only see 1 tire right now. She can only see my MR, and she says, "Oh, Steve, I'll fix that one, you're good to go." She still left me with 1 flat tire. I am not good to go. And amazingly, even with percutaneous therapy, TR is still bad, Molly, sorry. So TR is bad. However we treat the MR or the other disease, if we leave TR, it's bad. Surgeons know that. Fix TR. And it makes sense. I was a math boy in college, and this really is the concept of a bagel with a croissant around it. And it's called modular geometry. This is how this works. As that bagel or that conated bullet of the LV has to increase to compensate for both forward and backwards flow with mitral regurgitation, the LV gets really big. That's how it works. Do you think the RV just stays there and stays really tiny? No, it doesn't. It doesn't end up like this. It goes around it because it's attached to the LV, and that crescent gets pulled out, and this is what you have. Manifold geometry, where those points are, pulls that crescent around the donut, around the bullet, and you get mandatory TR. And that is why 75% of the patients that we operate on for mitral regurgitation have already shape changes. They've flattened their annulus. They've dilated their annulus. That egg has become an ovoid. It's already happened. Even if they don't have TR, they're in trouble. Surgeons know that. And again, it's mandatory to show this slide in a tricuspid talk. You must show this legally. So therefore, we know that this is super underutilized. And it makes sense. There's millions of people out there with MR, and they all have TR. They've all hurt their annulus already. Surgeons know that. Now, even though we know that, and the guidelines say we should do something because I'm there 1 centimeter away from the tricuspid valve, if you have moderate or dilated annulus, only 40% of the time do we do something to that. And it is a class 1 indication if you have severe TR to fix the TR while you're there doing the left side of the lesion. And look at this, 80%. Dr. Charles Barkley would say, terrible, just terrible. We're awful doing that. And what I'll often do is in a big meeting like this of surgeons, I'll say, who here would not fix severe TR while you're there doing the mitral? Raise your hand. And of course, just like you, no one will raise their hand. And I'll then say, well, great, I know that 20% of you, this entire row, are liars. Nice. So we need to fix it when we're there. We know that as surgeons. We've learned a lot. We used to know things that now we unlearned. We know to look for it not in the operating room, not before procedure. Don't go to the hybrid room, don't go to the cath lab, don't go to the OR, and make a decision about TR, because under anesthesia it'll go away. I would post case for an MVR and a TVR, and anesthesia would call me up and say, Steve, this guy doesn't have any TR. You don't fix that. And I'll say, great. I'll just fix his mitral, and you keep him under anesthesia for the rest of his life, because that's the only thing that's going to keep that TR away. We know that now. Does it go away by itself? Of course, we've all thought that it would just go away by itself if we fix the mitral, but it doesn't. This is a big series from the Cleveland Clinic. 16% had severe TR. 3 days later when they discharged at home, 2/3 of them already had severe TR. You had left them with a mortality ding. Don't do that. It does not go away by itself. And does that make sense? Well, of course it does, because you already know, because of manifold geometry, that tricuspid annulus, even if they don't have TR, may be super stretched. And that explains this vexing thing that we see as surgeons as a perfect mitral regurgitation repair. 5 years later, they come back with TR. That's almost all what isolated TR is. It's something that I didn't do at the time of surgery, and now we wait and we wait and we wait because the patient's had surgery to the point where they do have liver disease, where they do have kidney disease. We're just about to put formaldehyde in the patient, and then we say, well, maybe we should do something for the TR. Of course that's futile. The reason is that it's like a rubber band. That annulus is very much like a rubber band. Think of a rubber band, snap, snap, snap. Millions of times, billions of times that tricuspid annulus can flex. But just like a rubber band, if you overflex it and actually unhinge the fibers of the tricuspid annulus, it's a broken rubber band and it will keep on stretching. So if I go to the operating room and we already have a broken rubber band, we should fix that tricuspid. Does it help? We now know that it does help. This is the classic Dreyfus paper. This is 300 patients basically with MR. Half of them got a tricuspid repair, half didn't. 2 years later, with no tricuspid repair, 50% had advanced their TR. 2% if they didn't. Fix it while you're there. We know that now. And does it add risk? Well, of course it adds time, but this is a really nice paper in a modern series where it really doesn't add risk. The reason why we didn't do it, we were afraid because we were converting a single valve procedure to a double valve procedure. Obviously, it would add risk. Well, it doesn't really. How can that be? Well, because the patients don't have TR when you take them to the ICU. You've gotten rid of that. And this is a nice series. Again, it doesn't add risk. A nice series that showed that the patients probably do much better with the elimination of their TR. So don't ignore it, because if you ignore it and then I have to take it back, the incidence of mortality then is 10 or 15 or in some series even 30%. This is the worst operation we do as surgeons. Do it now while you're there. So we used to not know how to fix it. And we did all these little funky ways, a De Vega, a K-annuloplasty. We now know, and hang on kids, look, use a rigid ring. Less recurrent TR, better survival. Use a rigid ring. This is from Tyrone's series. This is from Tyrone's from Toronto. Use a rigid ring, better survival, less recurrent TR. This is a Cleveland clinic, better recurrence, better survival. This is the Montreal thing. Use a rigid ring. I just showed you data on 5,000 patients. Use a rigid ring. It's better than anything out there. A K cannot compete. A flexible ring cannot compete. Use a rigid ring. Why were we afraid of rigid rings? Well, mostly because of AV node injury. Because the original cases, as was said, it's almost all in rheumatics, and you had to really almost put a circumferential ring to fix a rheumatic tricuspid. We were afraid of the AV node, but now we know the anatomy. We now know this, and stay away from the AV node. That's dilating up and away from the AV node. You don't have to fix it at the AV node. And this is what we teach our fellows, the rule of 10. 10 stitches, 10 minutes, 10 o'clock to 6 o'clock. That's it. That's all you have to do. And in fact, all the manufacturers now show in their instructions and their pictures, this is how we do it. 10 o'clock to 6 o'clock, 10 stitches, 10 minutes. How to size it? Don't size it. You just don't size it. The normal size of your tricuspid annulus, if you go like this, it's basically that big. It is not super big. And in fact, if you put a 26 or 28 ring, you will be fine. And in fact, if you look at this data, the average size is 28 plus or minus 0.5 millimeters. It is very tightly held in a population. So why do we have 36 rings made by manufacturers? Because 36 is 14 standard deviations above the norm. That means of the 335 million Americans, who would fit a 36? There's 4 guys, that's it, and 1 woman, that's it. That's all would need that. The other 335 million of us should have a 28. And in fact, if you look at it, we now know that if you get it less than a 30, you're just not gonna get TR. If you get it higher, you'll get recurrence of TR. Now this assumes a normal right ventricle. If you do, as being told, wait until the ventricle is the world's largest croissant, you just can't fix that. And in fact, this is Jim Gammey's first paper looking at undersized TV repair, where he used a 28 and a 26, and everybody, it wasn't undersizing, it was actually re-normal sizing. And he started off with a lot of TR, and he ended up a year later with almost no TR. It's a good result. Oh, will I get stenosis? I'm afraid of putting such a tiny ring on. Did you go to college? We now know that if you go to college and understand math, you will not get tricuspid stenosis. Pi r squared, you will not get tricuspid stenosis, and it's really not ever being reported in thousands of ring repairs. How about RV failure? What about that pop-off, that blood going backwards somehow helps patients? There's no way that blood going backwards should ever help a patient. In fact, the big series show that the RV gets better. There's 2 clinical series, one from America, one from Europe. The patients get better when you fix their TR. What do the guidelines say? Well, the guidelines say, of course, severe TR, do it. Moderate TR, do it. Those are the American guidelines. The European, the same, severe, moderate. Do surgeons know that? Do we know that? We do know that. There's Jim Gammey's series. There's Dave Adams' series, 645 patients who they basically follow the guidelines. Far less TR recurrence over the next 2 years. Better RV function, no increased mortality, no pacemaker. This is ours that is coming out in the Annals of Thoracic Surgery this year. 262 patients in American series done exactly by the American guidelines. These are our results. We had 1% progression of TR. That is data on 1,000 patients done by the guidelines with a 26 or 28 ring. Surgeons know that this works. So this is what we know, to sum it up. TR is bad. Fixing TR is good, okay? I'm a simple surgeon. We don't really believe ourselves, so there is this CTSNet trial that Gorav and Jim Gammey and I are sort of pushing along because we don't believe that. We don't believe ourselves. And there's 400 patients, and we're going to follow them for 2 years. These are patients who had a mitral repair who plus or minus a tricuspid at the time of their operation for moderate or less than moderate with a broken rubber band. And we will tell you the answer. Now, Molly talked about percutaneous devices. What are the percutaneous implications of what surgeons know about TR? Well, what about these TR, these percutaneously not annuloplasties? What the heck? I mean, as surgeons, we say, what? How can that be? What about these things, clipping it or putting valves up the SVC or putting a giant plug in the TR? Well, I think we have to, as surgeons, sort of remain calm and carry on. It may be okay. If you think of it, it's all a risk-benefit decision of what we do for patients. And if you had some way when that patient first came into your office and you could say, I will magically get rid of your TR without any mortality or morbidity, you would do it. I would do it. I would do it. And I think percutaneous devices don't have to look exactly like we do in surgery. Stenting doesn't look like bypass surgery, but it's good. So I think we have to think about these patients, but they can't be proven at the far end of the bell curve. When the patient has the world's largest right ventricle and that ventricle is dead, none of these devices are ever going to work. They don't work when I'm looking at it point blank at the time of surgery. Let's look at it. This is the K, which is basically the mitral line, trial line, does not work at surgery. So why do we think that we could put a K in without seeing it, that it would work? It's failed before. Maybe there's a different way we can do it. Maybe it becomes a percutaneous de Vega if we put a whole bunch of them in there. But look at this, goal accomplished from this. Would you say goal accomplished with a 10 square centimeter orifice? No. With a regurgitant orifice of 1.5 centimeters, that's 4 times severe. Seriously, you think that's going to help a patient with a dead RV? It's not going to. However, at the other end of the bell curve, it may be okay to do that. Here's what surgeons know. TR grade 0 is the best, and really 0 to 1 is good. 2, 3, and 4 are bad. That's a mortality ding. So really, seriously, Becky, massive? Come on. And number 6, torrential. I think originally there was a number 7+, which was tsunamic. And if you move the patient from tsunamic to torrential, that would make a difference. It's not going to make a difference at the end of that. Surgeons know that TR is bad. The impact of TR upon you will not change with the method of therapy. A new grading method will not fool nature. Surgeons know that. What it'll take is a sustained, meaningful, early reduction of TR. And I think this is where all the percutaneous devices are going to play a great role. But what other things are going to happen? Well, there are percutaneous devices out there that look exactly like surgery, and I think that's what this is going to evolve to. The Cardioband has been put in a lot of patients, the Millipede has been in patients, and you can see that cardiologists can understand that. And in fact, Molly even says, I'll drink to that. That's what she says.
Really, Steve?
Cardioband has been put in almost 100
Seriously?
patients in the tricuspid position. And then Millipede has an extensive series of 2 patients put in the tricuspid position, and you can see this is a patient with both a mitral millipede and a tricuspid millipede. So, to summarize, surgeons know now, as opposed to what we used to think. We used to think the TR was not important. No, it is important. It has mortality ding. Look for TR in the OR. No, don't. Look for it earlier. There's not much TR around. Everybody up here said there's millions of patients with TR. Repair the mitral, the TR goes away. No, we now know that it doesn't. It adds operative mortality to the 2VR. It may not. We don't know how to do it. Yes, use a ring. The RV will fail. The RV will not fail. I will get tricuspid stenosis. No, we now know math. It won't do that. It won't make a long-term difference. Yes, it probably will. It will probably take that mortality ding away from you. The guidelines are vague. The guidelines used to be very vague about what to do to the tricuspid. They're not, and I think they're going to become more clear as we have this randomized trial come out. So, what do surgeons know? We know these things now. So we say the percutaneous community has to learn from surgeons, but also learn from Beyonce. Put a ring on it. Thanks.